Okay, thank you very much, and thank you for a very challenging presentation, but it really brought to the forefront the issue that we are dealing in complexity. And for me, it was also brought to the forefront that we have very complementary but very different ways of looking at complexity. I've got to say, every time people, and even hearing Igor talk this morning, when people say to me, okay, people come into treatment and they go out of treatment and they're no better, every bone in my body shouts, no, it can't be true. And I've been really thinking about that during the sessions. And I want to present a little bit of data from the longitudinal follow-up study, which is 11-year follow-up of 600 people who entered treatment for heroin dependence. Because I think, if you were to look at the whole group at the beginning and the end, they do look pretty much the same. But there are some really different individual trajectories that people followed. And for me, it's getting into the complexity of the data to try and understand what those different trajectories were. So the first thing, which always makes me feel, what's the Australian clinical research taught us about treating comorbidity? Sorry, they're all my collaborators, and thank you very much to all of them for working with me at 7 universities. And I'll put this up at the end, but that's our website in case people want further information. And acknowledging the fabulous treatment team and contributors to the research that I'm going to present. So I think, yay, I'm always comforted when you've got the same statistic that the person who presented before you has on their slide, because otherwise you're in big trouble. So you'll see I've got in red down the bottom there, 71% of people in mental health services. And 90%, I was going for 90% in Australia of people in substance use settings had comorbidity. So it's very common. And that's like taking Coles to Newcastle in this audience. I've got to say it's slightly more required within mental health audiences to remind them how common it is. But it's really Coles to Newcastle. And I can see sitting in front of me the person who's responsible for me being in drug and alcohol and coming from mental health. So it's a little bit daunting to see Wayne Hall sitting in the middle of the room. So, hi Wayne. Okay, the Australian Treatment Outcome Study. This also, while I was working at the National Drug and Alcohol Research Centre, Wayne said to me, wouldn't it be a good idea to follow up a few hundred people who entered treatment for heroin use and see what happened to them long term? And one of the big lessons I learnt from it was that comorbidity matters in the long term. And also that there's order. So we interviewed 615 people who'd entered treatment for heroin dependence, a very complex group. We did have 80 not in treatment at the beginning, but within a couple of months all of them had some exposure to treatment. And they came through the main treatment modalities. Maintenance therapy, detox, and residential rehab. And I'm going to put a picture up and you're all going to say, you haven't aged a bit, Maree. So this was a group of people who did this study, me. See, I look exactly the same as I did 10 years ago. Shane Dark, Kath Mills, Joe Ross, Alice Havard, Kate Hetherington, and Anna Williamson. The other thing this study produced was those 4 people at the front there all did their PhDs and are researchers in the field. So very proud of that too. So we decided to look at heroin. As I said, this session is about complex problems. And also because many people were seeking, and still do, seek treatment for heroin use in Australia. And we were curious about some big issues like for the first time measuring their comorbid depression and comorbid post-traumatic stress disorder. So they looked, quite a large proportion of them were male, average age was 29. If you'd done any sample in any of the surveys that were going on at the time, this is basically what the cohort of people entering treatment looked like. Okay, So we recruited 600 at baseline, and at 3 months we were very excited to find 89%. At 1 year we were again very excited to find 81% of people. At 2 years, 76%, and at 3 years, sorry, my little things at the bottom there have just shifted over slightly to the right, 70%. So some of the first researchers on the study who were doing the research with us, Kath Mills and others, they did the follow-up interviews for 3 years, and then they became the investigators on the study. So they were saying, there's no way we're going to do better than that at 11 years. And at 11 years, we interviewed 431. So we interviewed more people at 11 years than we did at 3 years. Actually, I think it was a lot to do with Facebook. Everyone was on Facebook. Can you believe that? We had 50 of the cohort. It's now closer to 60 were deceased at 11 years. Okay, so we've got a pretty good sample of what's going on. Where do we find them? They're very sensible. Can you see that there's no dots on the United States and Canada? But they did move all over the world and all over Australia. So one of the questions was, we don't know what happens over the long term, and are there some coherent patterns going on? Are there indicators that can tell us what's likely to happen over the long term? And particularly, what about comorbid disorders, depression, post-traumatic stress disorder? So you'd be thinking a simple message might be that if you've got comorbid depression and you've got comorbid post-traumatic stress disorder, you're just not going to look as good as the groups that don't have it at the end of 11 years. But is it as simple a message as just that? So at 11 years, actually the major depression rates looked pretty much the same. Thankfully, they were all statistically older at 11 years than they were at baseline. Otherwise, I would have really been worrying about the data. And, 11 years older, thankfully. And we wanted to look in this group at their trajectories. So this isn't, where's the whole group? It's, are there some common pathways that people followed over the 11 years? And we weren't sure if there would be common pathways or whether there would be 15 pathways or whether we just would not be able to model this sort of data. For me, even though this system is incredibly complex, what's fascinating is that we actually found 6 pathways of heroin use over the 11 years. And what were they? And see if they make any sense to those people. Are there people here who are running treatment services for individuals entering treatment for heroin dependence? See if they make sense. So we had about 16% of people. We had a group where they were the early decrease to maintained abstinence. So it took a while, took a couple of years, but they were able to maintain their abstinence. There was a group where we had an early decrease, well, what we called early, but over a couple of years, 1 to 2 years, and then they relapsed, so they went back to use. And there was a group that had early decrease to, they did really well, but at the 7 or 8 year mark, things started to go pear-shaped again. So again, it took 1 to 2 years for people to decrease, but then maintained that decrease and then increased later. There was a gradual decrease to near abstinence, which is about 20%, fitting that curve. And there was a group that really, it was 6 or 7 years before, or 5 or 6 or 7 years before you started to see a reduction in the heroin use. And then finally there's this group. Isn't this group phenomenal? This is a group where, there was no decrease in their heroin use over 11 years. My slides just cut off, but trust me, it goes through till 11 years. Okay, so the question is, can we predict any of these? Now, first thing I'm going to do is throw up the variables which we had at baseline that didn't predict what was going on. Actually, the first thing I'm going to do is give you the spaghetti graph of all of the different patterns. The next one is I'm going to tell you about the factors not associated. So male, gender, homelessness, prison history, past month criminal involvement at baseline, that wasn't associated with which pathway. Number of drug classes used, types of drug classes used, or history of injecting drug use. Physical health, antisocial personality disorder. Current and lifetime trauma and depression. A number of traumas wasn't associated. This is at baseline. And also whether they were in current treatment at baseline and whether they had an index current treatment category, index treatment category, what sort of treatment they went into. I was starting to despair that nothing was going to allow us to predict what was happening with these people. But there were some predictors at baseline, and they were these 5. Ever overdosed, severe mental health disability, experienced rape, aged less than 30, and used heroin for less than 10 years. Now, because this talks on comorbidity, I'm just going to present which of the graphs was related to severe mental health disability. Now, I don't know if you can keep those graphs in your mind, but just have a think about which one you think might be related to severe mental health disability, and I'm now going to show you. Those with severe mental health disability were significantly more likely to be in the early decrease, so they did okay over the first few years, but then they had an early relapse. So severe mental health disability, as measured on a very simple measure, which was the SF-12, at 3 years there was something critical going on that if you didn't pay attention to the mental health disability at baseline, they were the ones who were going to flip back to use following that 3-year period. So for me, it's that there's some order there, and that if you don't pay attention to it, then at 3 years you get the increase in the back to the heroin use. But it's not like it's immediate. It takes some time. Okay, so, but I should also say, nothing predicted this group. And that fascinates me. Who is in this group? And the fact that none of the things that we measured at baseline could reliably predict who were going to be in this group that continued to use and were still using every year from the entry to the study till 11 years later. Anyone got any ideas? I'm happy to hear them. Okay, so the comorbidity matters in the long run. More than 80% of the cohort achieved some level of reduction in their heroin use, but there are critical factors, including severe mental health disability, that can predict what patterns individuals will follow. What can we do? We actually lead the world in new treatments for comorbidity. Australia has more randomised control trials either published or running than anywhere else. We love complexity and we love challenging that complexity. So the second bit of my talk was to give you a quick overview of what we've found in terms of treatments. So there's 29 ongoing Australian research projects. We've got clinical trials, 10 randomised control trials across psychosis, PTSD, depression, alcohol dependence, drug use, social phobia. These are just the ongoing ones. The fantastic Leanne Hyde sitting in front of me has run her own trials in this space. And just since January 2014, there's 84 peer-reviewed journal articles, not just on treatment, granted, but there are large numbers. In terms of treatment for post-traumatic stress disorder and substance use disorder, so that was one of the comorbidities that we observed in the 11-year follow-up, This is a paper published in the Journal of the American Medical Association of a randomised control trial of exposure-based therapy and behaviour therapy and exposure-based therapy for trauma in those with substance dependence. And what did it find? It found that the collective wisdom is a load of rubbish. If you treat the PTSD, the drug use will escalate. If they're still using, then they're too understable to treat the PTSD. No. At baseline, in the treatment group and the control group, this is diagnosis of PTSD. Both had a diagnosis of PTSD. At 6 weeks, the treatment group no longer had a diagnosis of post-traumatic stress disorder. The control group did. That's post-traumatic stress disorder, but did their drug use increase? Let's have a look. If you look at their severity of dependence, just as one measure of drug use, it went down from baseline to 6 weeks, but critically, it didn't go back up again. At 6 weeks to 3 months to 9 months, it stayed pretty flat. And we didn't get a difference between the control group and the treatment group. So if you believe the clinical wisdom, the substance use was going to go haywire once we treated the post-traumatic stress disorder. So across a 9-month period, both groups had improvements and they didn't get worse. The manual for this intervention, just slide for that's just slipped away somewhere, but it's just been published in the Oxford University Treatments at Work series, so if anyone's interested in that, it's access to it via our website. The other side of it is, that was a face-to-face intervention and it takes a lot of time. I know Leanne's going to cover the use of internet interventions, but Australia is the innovator of e-health interventions. We've just recently completed a trial of an online intervention for depression and problematic alcohol use in young people. I heard 2 talks in the last session talking about using online interventions for substance use with young people, and we should be doing the same thing with comorbidity. There's effective evidence-based interventions out there. And interventions that take a holistic approach. Again, online effective interventions. This one's a healthy lifestyles approach. The challenge, everyone's, there's a load of evidence out there, but the challenge isn't now, as it was 10 years ago, trying to find the evidence base for effective interventions. The challenge now is how to translate that into practice. We're working with New South Wales Health and mental health commissions and clinicians and drug and alcohol clinicians to try and develop a tool for clinicians so they can get access to these interventions. We're doing a pilot site in one rural and one metro site because there's no point doing clinical trials and having the evidence in the literature if it's going to take 10 to 20 years before it actually gets out there. Our hope with the comorbidity work is we've built up enough of an evidence base now that we can start to develop, start to pilot some ways that we can get the information out there, either by individuals using the interventions online and integrated into clinical services, or providing knowledge to the clinical services about the face-to-face interventions. So we've just started doing that online tool development, and if anyone's interested in talking to us about that as we develop it, then please come and talk to us or email us at the comorbidity.edu.au. Thanks very much.